Great. Good morning, everyone. Welcome to Ocular Pathology Rounds on July 8th. I am Gillian Shaw, and maybe I can get the slide to advance. There we go. The first case that I'm going to present is an eye from a 15-year-old domestic short-haired cat. They say Max's, oops, sorry, cat's name was Max. That's pretty generic. Anyway, this eye was demonstrated severe periocular swelling extending well beyond the globe. Marked exophthalmos, prolapse gland or third eyelid prolapse with visible medial canthus and darker tissue, likely uveal, protruding from the superior aspect of the globe. The right eye, which is the other eye, appeared normal with an intraocular pressure of 19. So this left eye was the only one that was abnormal. When we received the globe, we remarked that it was extremely ophthalmic and that it was the cornea was opaque. How do I get that? Oh God. Man.
I saw nothing.
It's that kind of a morning. All right. The cornea was opaque, and it was filled with this material. Some of it was more solid and tan, and some of it was a little bit more translucent and gelatinous. The lens is right here, the iris is here. And this, I think, was the dorsal aspect where they mentioned the superior bulging or uveal something or other. And what we have is the sclera bulges outward here. The cornea is quite thickened in that area, and there's a lot of that similar material expanding that space, which would be the suprachoroidal over here and the supraciliary right here. The retina is difficult to identify, and we cannot see the optic nerve head here. And the uvea itself, I think this was probably a blue eye at some point. They did not tell us what color the eye the cat had, but the fact that there's very little uveal pigmentation could be because it's a blue eye. Could also be because of what's going on inside this eye. Another bit of really sad information about this eye is that it was frozen solid when we got it. So we actually received this globe in January, and it must have been after a cold snap because, as I said, oh, it was frozen solid. All right. So let's do this. That's not working today. All right. So here is our eye. This is the subgross view. The cornea is off to the left, right here. We have anterior chamber. Here's the iris, the lens. And then as we move back, there's a lot of stuff in the posterior segment. And then we did not, oh, here was the optic nerve right here.
Wow.
So there's the retina. And then this was just an extra slice of the eye there. So there's a lot of stuff in this eye that's filling the chamber. However, it's not very darkly stained. So it seems to be sort of an interesting type of stuff. All right. So start up there by the cornea. Well, okay, here we go. So, as I said, this globe was frozen. And so this is a beautiful case demonstrating what the horrible things that freeze-thaw artifact can do to a fixed specimen. So basically all of these clear, completely clear spaces are due to things freezing, forming crystals, and then melting, and then washing away. And so what we have here in the anterior chamber is homogeneous proteinaceous stuff. And so it was just a protein-rich aqueous humor, probably.
That's the glaciated area.
Yeah, right. And then, so for example, a lot of these spaces in the corneal stroma are probably also partly freeze-thaw artifact. The cornea was quite opaque, grossly, and that could also indicate that there was corneal stromal edema. But as we move back, we're going to figure out what's going on back here and figure out what all this stuff is. So once again, a lot of this, the appearance is freeze-thaw artifact, but let's zoom in here and take a look at what's going on. So what you might start to pick up are not only is there a lot of clear space, but there are also a lot of pale-ish basophilic dit dots, some of which are in smaller clear spaces. And as we go higher, we have abundant yeast. So that's a yeast, and it's surrounded by a very large halo of clear space. This is characteristic of Cryptococcus, which have very thick capsules. Histologically speaking, the clear space that we see around them is at least partly due to shrinkage, like artifactual shrinkage due to fixation of a thick capsule. But if you do a muci-carmine stain or an Alcian blue stain, or it may be a PAS as well, that does highlight the capsule a bit. But anyway, the other characteristic feature that we would be trying to find if we're trying to feel more comfortable calling this Cryptococcus is narrow-based budding. But I did not mark any on this slide. I'm sure it's, oh my gosh. Wow. Look at that.
Excellent.
So that's a nice example of narrow-based budding, and we say that to differentiate it from blastomycosis that has broad-based budding. Blasto's often bigger as well. So this globe is completely filled with, just about, with Cryptococcus organisms and relatively little inflammation. And that is pretty characteristic of Cryptococcus infections in probably the entire body, but certainly in the eye. And when we move back to the optic nerve, it is also completely effaced by yeast organisms. Just go higher. And Cryptococcus is known for its love of neural tissue. It likes to actually form or infect the brain, where it likes to form these, at least grossly speaking, these big gelatinous accumulations. And that's one of the characteristic features of it grossly is that it has this gelatinous appearance. So in the brain, they talk about cryptococcomas because they form these relatively well delineated gelatinous mass lesions in the brain. This we also received all of the orbital tissue from around this globe, and it was all completely effaced by yeast. So this cat had a really significant, at least local infection with pretty significant concerns for the brain because of what's going on here. Because if it wasn't in the brain already, it looks like it's going to be traveling up the optic nerve toward the brain. Oh, I mentioned that I couldn't really identify the choroid very well, but actually here it is. So this is not a blue eye. This is a pigmented eye, and it's just that the pigment is sort of dispersed due to all the stuff that's going on in the eye. And in fact, here's the tapetum. And there would have been retina here somewhere, but it's hard to identify now. So I'm not going to dwell too much more on the features of this case because of the freeze-thaw artifact, because it was pretty detrimental to admiring the other histologic features. So we'll just go right to the diagnoses. So as I mentioned, there were not very many inflammatory cells. That's pretty characteristic. And when I was training, we had an old school pathologist who taught us this phrase, leukocytically pauperous inflammation. In this case, granulomatous inflammation, panophthalmitis, and orbital cellulitis with myriad intraocular yeast organisms whose morphology was consistent with Cryptococcus species. So they did not seem to know that this cat was infected with Cryptococcus, or at least they did not provide that information for us. So with most intraocular yeast or fungal infections, we assume that they are systemic and that they are just now sort of affecting the eye, as opposed to, I mean, probably you can get local inoculation via traumatic injury to the eye, but generally speaking, we consider that to be fairly unlikely in most cases that we receive with intraocular fungal infections. The lack of inflammation is probably related to the capsule of the yeast in this case. So the body really does have a hard time fighting Cryptococcus infections because of the capsule. And yeah, any questions? All right.
Yeah, some worrisome prognostics for the potential symptoms.
Is the cat still alive?
Yeah, definitely concerning for this cat's CNS as well as the rest of the cat. I have no idea if the cat is still alive. We never received any more feedback. So, it was just such an impressive case that I wanted to share it. And then the freeze thaw artifact. Oh yeah. So all of you going into practice out there, if you're going to take specimens in the wintertime and put them in formalin and fix them to any kind of diagnostic service, please add some alcohol. It can be ethanol or rubbing alcohol. It doesn't really matter, but we usually recommend ethanol to about 10% of the volume. And that will help to prevent it from freezing. However, if you know that it's going to be below 0, I recommend you wait a few days to ship it. Or ship it overnight, because the problem is that the samples sit on a truck overnight that's not heated. And then that amount of time, especially if it's over the weekend, they're often frozen solid. And it really does hinder the ability to evaluate a sample, especially when you get into like minute details, which occasionally are really important for cases. This case was really obvious what was going on, but
Yeah,
anyway.
we're lucky. It was
Yeah.
Cryptococcus, and it was basically
Yeah.
an ocular cryptococoma. Is that what you call it?
Yeah, right. Yeah. Yeah. Anyway, so good lessons to be learned there. All right. Moving on. The next case. This is an eye from a 12-year-old cat whose name I will not share with you. It is a spayed female. The globe appears ophthalmic. It was blind, and there was diffuse corneal edema, a large central superficial stromal corneal ulcer, peripheral circumferential deep corneal neovascularization, and they were not able to see anything else inside the eye. The patient's other eye has a high normal IOP of 24 millimeters of mercury, excuse me, um, and positive menace response, but also a dark optic disc. So they didn't really come right out and say that they were concerned about the other eye, but from what I read into that, I was a little bit concerned that something else was going on with the other eye. At any rate, we'll maybe get there to discuss that. But here is the eye. Cornea is always at the top. It is a little bit cloudy. As they mentioned clinically, you can kind of see this reddish hue to the peripheral cornea here, and that is going to be that neovascularization that they mentioned clinically. What is really interesting about this eye is that here's the limbus, and then the base of the iris is way back here. So the base of the iris really should be right about here. So this is a significant iridocorneal angle recession. So remember that the iridocorneal angle is where the iris base meets the sclera. And when that is posteriorly displaced, as in this case, we call that iridocorneal angle recession. This is a bit of a mysterious lesion, and I'll get more into that in a little bit. What we can also see is that the iris itself might be a little bit thickened and irregular, so there might be something, an infiltrate of some sort going on in the iris. The lens itself is pretty boring. The back of the eye is also pretty boring, except that the optic nerve might be a little bit bigger, optic nerve head rather. It might be a little bit bigger than we normally expect in cats. Cats always have a little bit of a cup that's called the physiologic cup. That's because the axons of their retinal ganglion cells don't myelinate until after they leave the eye. Where compared to dogs, where they myelinate right at the optic nerve there, optic nerve head, and then so you have like this sort of fluffy myelinated optic nerve head normally in a dog. So really, but other than that, the posterior segment looks pretty boring. So let's go ahead and jump into what we have here.
Mine are myelinated in my retinas.
Oh,
You can see them on imaging.
cool.
Yeah,
Hopefully that's okay.
it is. Makes it look opalescent in some areas.
Huh. Interesting. All right, so what we have on this slide is this is an extra slice of the eye. We like to call that our gonio slice. Sorry, it's hard to get everything into focus. So here's the cornea. We don't have it completely sampled. There's the lens. I'll just move this direction. So the limbus is where the cornea meets the sclera, and that's right about here. So you can see that darker eosinophilic hue of the sclera, and there is the sort of lighter eosinophilic hue of the cornea. So that's the limbus right there. And the base of the iris should be right about here. So we have really significant posterior displacement of the base of the iris, and so we call that iridocorneal angle recession. Here's our little iris. It's looking a little bit purple, so that usually indicates that there's some sort of infiltrate there. And the ciliary body plica are a little bit oddly positioned here. Normally the ciliary body plica come off the ciliary body as it sort of is flattened up against the sclera, but here they're sort of coming off sort of that armpit of the iris instead of coming off from the sort of more flatter area here. So that is an abnormal location of the ciliary body plica. And that is true over here as well. This is a little bit harder because it's artifactually the iris is artifactually fragmented here. But once again, what we have is the ciliary body itself is also sort of separated from the sclera here. So that's a really beautiful example of what we call cyclodialysis. That means cyclo refers to the ciliary body, dialysis refers to separation. So we have separation of the ciliary body from the sclera in this case. Cyclodialysis is a sequela of blunt trauma. So right off the bat, especially seeing the ciliary body and how it is separated there, I'm already thinking about blunt trauma for this eye. And then as we move back, let's see here, the optic nerve looks a little bit recessed. Normally it should be a little bit flush with at least kind of the choroid here, and it's a little bit recessed. The retina is hard to assess from this magnification. So let's go ahead and go higher mag. So we'll start here in the peripheral. Oh yeah, they also mentioned there was a corneal ulcer. So that is true. I forgot to point that out, low mag. But so here is corneal epithelium where it is still present and then it is absent. So that's an ulcer. And then we have stromal infiltrate here as well. So we've got some neutrophils, and this is probably one of the reasons why the peripheral corneal stroma has become vascularized, because blood vessels are moving in to try to fix the problem here. So there's the corneal ulcer. There we go. We can see a bunch of little blood vessels occupying and infiltrating that the peripheral corneal stroma, which is part of the corneal healing response. So here we have, as I said, the base of the iris is very posteriorly displaced. It should be up here somewhere. And normally the aqueous humor outflow tracts should be right about here somewhere. So the sort of channels of the angular aqueous plexus. And those then meet up with the veins of the scleral venous plexus, which is right here. It's an example of one. This weird gap in the sclera, I'm not entirely sure what the deal is with this. I don't know if this is simply associated with the severe inflammation that we have here, or if this is something traumatic. I'm not really sure. My gut feeling is that it's related to the inflammation, but I can't really tell for sure. And what we also...
This looks like separation at the aqueous drainage structures sort of
That's
level.
what I was gonna say, right about there, looks like you've
Trauma
got
or inflammation, both of them.
Yeah, it could be.
Pretty
Right.
cool.
Yeah, and what we also have here is deposition of a paler, looser maybe form of collagen. So this is fibrosis. So if we could identify the trabecular meshwork, I would call it trabecular meshwork fibrosis, and that's probably honestly what I did call it. But this no doubt also hindered the aqueous humor outflow from this eye, thus elevating the IOP. So I mentioned that there's a bunch of infiltrate here in the iris stroma. Whoop. And when we look higher mag, typically what we're going to find, especially in cat eyes, is a bunch of lymphocytes and plasma cells. So and that indicates this is very chronic inflammation in the iris and ciliary body stroma. I was looking for some plasma cells. That might be one right there. But anyway, this is pretty lymphocyte heavy. Sometimes we'll also find Mott cells, which is a great indication that this is very chronic inflammation. And we have a bunch that are sort of lining up along the surface here. There might also be a pre-irrital fibrovascular membrane mixed in here. There's one blood vessel right there. You can see it, but it's a little bit hard to define well here. And the inflammation does extend back into the ciliary body stroma, which once again, as I mentioned, is quite distorted because these plicae should be coming off this area of the sclera instead of the back of the iris or the iris's armpit. And let's see here. The lens was pretty boring grossly. But we do have, go higher again. We do have, so this is the posterior lens capsule. It's the thinner lens capsule. And we do have, it is lined by lens epithelium. Normally the lens epithelium should not ever get back this far. And it should end at the lens bow, which is at the equator over here somewhere. So when it migrates posteriorly, that's one of the features of cataractus degeneration. And then we're going to move back and look at what we have going on back here. So we have not very many retinal ganglion cells remaining, at least they're centrally, but we do have maintenance of the inner nuclear layer here and the outer nuclear layer. And I think that's about it there. And the same is true on the other side. So retina is relatively normal, but no ganglion cells. And then the optic nerve head, which might be imperfectly sampled here. There is pretty good evidence that it is atrophied though, here. So, and this pink stuff, if you're wondering, is probably condensed vitreous that's kind of stuck to the optic nerve head there. I'm actually not 100% sure what that is. Anyway, so those are the main features of this eye. So let's go back to our list of diagnoses. So there's a lot going on here. As I said, the left eye, which was the other one, had a high normal IOP and an incomplete direct pupillary light response. So maybe there's some sort of vision abnormality there and a dark optic disc. Usually that means that it's atrophied in cats and dogs, I guess. So this is a large laundry list of diagnoses, many of which I touched on. Oh, I forgot to point out there's a peripheral break in Descemet's membrane. Peripheral breaks in Descemet's membrane we also consider to be the result of blunt trauma. So severe corneal angle recession with distortion and fibrosis of the trabecular meshwork, severe lymphoplasmacytic anterior uveitis, loss of retinal ganglion cells and optic nerve head atrophy. I listed the differential in this case of chronic secondary glaucoma versus optic nerve damage associated with trauma or both. So my gut feeling was that this globe suffered blunt trauma. However, that doesn't explain the severe lymphoplasmacytic uveitis that we have. So cats are the hallmark creatures for us in Coplow, at least, of idiopathic lymphoplasmacytic uveitis, whereas in which we don't know what the cause is. So trauma itself doesn't lead to that kind of chronic inflammation. So chances are this cat may have had an infectious disease at some point and or which triggered uveitis, and or this can also be a sort of autoimmune disease triggered by some sort of an infectious disease. So in other words, the antigen never was or is no longer in the eye, but we have this persistent inflammatory response, which can lead to things like fibrovascular membrane formation and synechia formation, which then could lead to glaucoma. Also, the inflammation itself can actually decrease the inflammation, the aqueous humor outflow if it's depending on where it's positioned in relation to the aqueous humor outflow tract. And also, cytokines related to inflammation probably are the cause of the trabecular meshwork fibrosis in many cases. In this case, I could also argue that I think trauma may have played a role in that fibrosis as well. So, all kinds of reasons for this eye to be blind. They did not tell us about any infectious disease testing that they may or may not have pursued for this patient. And it sounds like they weren't necessarily concerned with uveitis, but I'm not sure how well they could have seen into the eye by the time the ophthalmologist was evaluating it. So with that, I will move on. Next up is Jamie Miller. Morning.
Next pathologist, I'm going to show the next two cases. I'm going to start us off with a 24-year-old thoroughbred mare. We got the right eye. And on ophthalmic exam, they described a subepithelial crystalline corneal degeneration that was multifocal, and that was associated with diffuse fibrosis and superficial vascularization that they said involved about 80% of the corneal surface. They also mentioned multifocal facet formation, but said that they did not see any infiltrate or ulceration currently. They weren't really able to see much inside the eye because of the corneal disease, but they said historically the globe was fairly unremarkable except for some mild multifocal chorioretinal bullet hole lesions, which are usually small, like circular scars in the retina from some unknown cause, either like ischemia or inflammation type thing. Usually doesn't affect the function of the vision in the eye. They said that the eye did not have any glaucoma, and it had been going on for years, and that the other eye was normal. So this is our gross hemisection of our globe. It's tilted quite a bit just to show some of the features. Here is our cornea. It was kind of cloudy to opaque, and we did note these multifocal kind of like white spots in the cornea as well. Uvea and lens looked okay. It was tilted a little bit because the person who grossed this noted that there was like a small 1 millimeter diameter kind of white nub by the optic nerve head, which I think might be here. That was a little bit deeper to the ONH, and they thought maybe it was incidental. They didn't really want to potentially cut up the globe to try to go after it. But we noted it, and we were curious if maybe that could represent maybe one of those bullet hole lesions that they were seeing clinically. So let's take a look at what is going on.
About the water droplet appearance of the retina.
Thank you, Dr. Gasper. Dr. Gasper wanted to know why there were sort of water droplet looking things here. So this kind of thin tissue paper looking material is the retina, and it is quite wrinkled here. And that's usually just a processing artifact when we cut it, especially in these larger horse globes. They can get wrinkled and artifactually detached. See, probably not a whole lot to see subgrossly here. So here is our cornea up at the top. You can see it's a little bit irregular, a little bit, maybe some areas with some darker purple. And as you just sort of float around, there's, like I said, the most of the rest of the eye is fairly unremarkable. Here's our iris, a nice open angle. Here's our lens, all the way, can't even get it on the screen, gonna turn it sideways, back to our optic nerve. Unfortunately, we did not sample that little lesion that was noted grossly. We did make note of it in the gross report and told the submitter if they were really super interested in it that we could do some additional stuff, but sometimes it's harder with these larger globes to get some of those smaller lesions. So we left it up to the submitter if they were truly interested in more, since we had given them an answer, I think, for their corneal disease. So here is our cornea. We can see that the corneal epithelium is a little bit hyperplastic. It's starting to keratinize. You've got little flakes of the keratin kind of sloughing off from the surface. And there is a bit of a little cellular infiltrate here, mostly lymphocytes. We do have some blood vessels. This is a little bit wrinkled here, but you can see the red blood cells in there. And as we travel along, up to it. So we have a region here where the corneal epithelium kind of takes a dive and runs perpendicular to our corneal stromal fibers here. So this is a little area of corneal stromal loss, and that has been re-epithelialized by this hyperplastic epithelium. And so this would correspond with what they were seeing as facets here. So just some previous ulcerations that have been re-epithelialized. And again, we just have a little bit like a lymphocytic, occasionally plasmacytic infiltrate here with some blood vessels. Then I have some smaller sections, especially when we have multifocal lesions and when we have these larger cassettes. It is sometimes nice to get some smaller sections in a regular size cassette in case other things need to be performed on the tissue, like special stains or immunohistochemistry. It's a little bit easier and a little bit cheaper for us to have that done. So we've got some extra little slices here that include the cornea, and we can see in other areas that the infiltrate gets a lot more dense here, but it still sort of maintains its sort of lymphocytic and occasionally plasmacytic infiltration. There's a little bit of pigment accumulation here, probably in some macrophages.
What is the pigment?
Probably some melanin pigment. I think some of the epithelium did get a little bit pigmented in areas. Could maybe even be a little bit of hemosiderin from previous
Yeah, it looks like
hemorrhage.
a little bit.
Mhm.
It's kind of
So-
interesting because that suggests corneal stromal hemorrhage,
Hemorrhage,
which is not
mhm.
a very common, feature.
Yeah. Yeah, and then we have some areas where there's just a lot of apoptotic and sort of necrotic cellular debris. So presumably from apoptotic or necrotic lymphocytes from that cellular infiltrate in our cornea. So so these features with the lymphocytic infiltration, the vascularization, this apoptotic cellular debris, there's maybe even a little bit of edema here. These are all features of immune-mediated keratitis in the horse. I did not see anything that looked like it was maybe neoplastic transformation of these population of cells, which is something that we can see sort of long-standing cases of immune-mediated keratitis. They usually come with a history of a horse that is being treated and all of a sudden it just stops responding to the treatment. So if that happens in one of your cases, you've got to maybe consider that your infiltration is no longer immune-mediated or inflammatory, that is maybe has become neoplastic, something to consider. But usually immune-mediated keratitis or IMMK is usually kind of a recurrent and non-ulcerative keratitis. So it's interesting that there's some facet formations here, which indicates usually previous ulcerations. It's usually more often by unilateral in the horse eyes, but it can be bilateral. And it's just important to rule out a potential infectious component as well. Once you do that, it's sort of left up to immune-mediated this. And like I said, there is a potential with the chronic inflammation for it to transform into lymphoma. In those cases, we usually consider those kind of a localized lymphoma and not really a systemic one.
Is that a specialized font for Coplow with the weird flags coming off some of the
Well,
L?
that is
It's the
street
TV.
Yeah, it's that one.
It's
on all of them.
Okay.
It's on all of them. So I'm just curious.
Yeah,
It's
You
not,
guys,
it's not on the computer.
It's not on the computer. So if you're seeing little flaggy things coming off of our,
No, it's not.
it's not on the thing. Okay, fantastic. It's just us. We just get a little extra flair in our diagnosis here in the room.
You're running away.
All right.
Oh, yum.
Okay. So next up, I have the left eye from a 7-year-old female spayed French bulldog. They described some moderate discharge, lag ophthalmos, and entropion, presumably of the eyelids, with severe corneal desiccation and severe corneal pigmentation of the left eye. They were unable, not unsurprisingly, to see deeper into the eye to assess what was going on inside, but they did say that there was no glaucoma, and this has been going on for about 3 years. So we have a lovely clinical picture here of all that desiccation. We've got this bright yellow material on top, which is probably fluorescein stain, trying to see if there is any ulceration there. They did not say one way or the other. It's probably a little bit hard to tell, but there is a little bit of a mass effect here, which they noted clinically. And so on our gross exam, here's our hemisection, here's our cornea at the top. We can see our cornea has a lot of pigment here. It kind of disappears here and it gets a little bit thickened and irregular here. So this is, this globe was cut on a horizontally. Normally we do a dorsal ventral cut, but we wanted to sample this little thickening in mass material. So we did a horizontal cut. And so this happens to be the lateral limbus here, which becomes important later. But the rest of the eye was relatively unremarkable inside. So we have our lens and our iris. This happens to be a picture of the other half of the globe because there's no optic nerve back here. I just wanted to have a gross picture of what I'm about to show you. So we're a little bit flipped 180 degrees. That's right. So this is where our pigment is here on this side. So you can see it coming along. Our superficial cornea is quite blue or purple, which we will take a closer look at. And then we can see this sort of abrupt change here in this mass effect over here with some other structures in here that some of it you might be able to recognize from this low power. Kind of looks like discrete clear spaces and maybe more dense collagen. We'll take a closer look at that. And then again, another one where most of the rest of the eye is fairly unremarkable, no evidence of glaucoma or cataract or anything else. We're going to start over here. Like a good French bulldog, we have a nice example of pigmentary keratitis here. So our corneal epithelium is pretty moderately hyperplastic. It's starting to form these reedy pegs. Some of them are a little bit anastomosing here. If we get a little bit closer, we can see that I keep losing my tissue when I flip the things here. Sorry about that. Let's try this again. All right. Here we go. Flipper. Here we go. So we do start to see a little bit of melanin pigment in here in our basal layer. We can see that the corneal stroma is quite vascularized, as well as these macrophages with this melanin pigment in their cytoplasm. So there's pigmentary incontinence. And then just a general like lymphoplasmacytic inflammation in the stroma, probably some neutrophils kind of exocytosing through the epithelium as well. And then as we keep heading towards our mass lesion over here, so we have nice kind of paler eosinophilic corneal stromal fibers. And then we hit an area where kind of the superficial cornea is replaced by these more dense and haphazardly arranged collagen. It elevates the epithelium here, and you start to look at this and you're like, oh, these structures shouldn't be here. So if we take a closer look, we've got sebaceous units We've got apocrine ducts. We've got blood vessels. In here, if I can keep it in focus for you, there we go. We've got some adipose tissue as well. More adipose. Again, there's that corneal stroma deeper. And we've even got a hair follicle or two around here with some hair shafts in the center. So this is looking a little bit more like skin, and skin should not be under cornea here.
Dermatitis.
So this is a congenital anomaly. This is a dermoid. So we've got some normal anatomic structures, our haired skin, basically, in an abnormal location here in the cornea. It's huge. They called it a small dermoid clinically, which
occupy the entire cornea.
no,
Yeah.
no, but
Subtotal.
but it is cute and adorable.
How old was this dog?
7.
Gross.
Yeah.
Yeah, very high for 7 years.
Yes.
It's a hairy situation.
It is a very hairy situation. Thank you, Dr. We also did get the third eyelid as well. It's got some changes in it. So our conjunctival epithelium is also a little bit hyperplastic and is kind of thrown into these kind of short papilliferous folds by lots of inflammation that was mixed, lymphoplasmacytic, maybe even some rare follicle formation starting to form here. It does go a little bit into the third eyelid gland, which is also a bit atrophied. We've got a lot of fibrosis kind of in between the lobules, and we've got kind of atrophy and loss of our glandular tissue, and our ducts are a little bit ectatic and kind of filled with secretory material as well, and a few neutrophils. So there's a lot of changes in our third eyelid. They didn't mention dry eye in this case, and we don't always have a good correlation between our histologic changes and what they're seeing clinically. But some of these could be severe enough that it might be affecting the tear film and contributing to the corneal disease in this case.
Yeah, just the presence of the dermoid for whatever 7 years, mechanically. You guys imagine yourself, like you got a little bit of something in the eye. Got that feeling. I got 7 years of hair and skin in your eye. That's how chronic we're talking about the process.
Maybe it's like going nose blind, or eventually you just don't feel it.
I can only hope.
Yeah. So here's our morphologic diagnoses. Like I said, pretty good. Like pigmentary keratitis in the corneal stroma, in the cornea itself, with that corneal dermoid, which French bulldogs, as this patient are commonly affected. And the lateral limbus is also a very common location for the dermoid, which is where this one was coming from. I think that's about it. Pigmentary keratitis is usually pretty common in our brachycephalic breeds, probably from just flat faces and dry eye and all that lovely stuff that they and eyelid abnormalities, which they noted clinically too with some entropion and stuff. So just lots of stuff irritating the cornea.
Yeah.
Anything?
French bulldogs are commonly affected by everything.
Oh, yes. Because additional history, it was also a good bulldog. It had brachycephalic airway syndrome, syringohydromyelia, caudal occipital malformation syndrome, and atlanto-occipital overlap, and kyphosis as well. So lots of other fun things going on in the dog.
Distracted from that.
Yes, it's got other problems to worry about.
Probably also only thinking about food.
All right. Hello.
I have some cases. All right. This is a clinical photo. We have a 12-year-old Persian spayed female cat. So we have this clinical photo here, which is showing an earlier stage. They describe these kind of tan keratic precipitates. They describe this raised kind of light brown or tan mass in the iris. And then a little bit later, this is what the kitty looked like. A little bit clockwork orange here. Apologies for that. But We still have that raised tan mass, and then now the rest of the iris has gotten noticeably browner, and there's kind of this multifocal raised appearance in the iris as well. So mainly the iris changes, plus some keratitis precipitates and other shenanigans, resulted in the enucleation of this globe. They also note that while they were doing enucleation, they noticed dark material in the eyelid, and so they submitted some eyelid biopsy as well. Starting full screen. Make it full screen. Ah. No. Oh. Aha. Okay.
Noticing
Fully opening the field diaphragm. Okay.
That beautifully sampled nodule.
It's
That's
so
amazing.
cute. Look at this little bump lump in the iris. It's adorable.
almost like you could see it when you were sectioning.
Almost, almost. And here we have a little bit of a lower profile iris, but we'll take a closer look at that. You can't really see much at subgross. All right. Here we go. Start over at that bump lump. We have a highly cellular neoplasm, which is kind of arranged in intersecting streams and sort of solid regions. These cells are polygonal to spindle-shaped. They have a mostly eosinophilic cytoplasm, a vesiculate chromatin, distinct nucleoli. There's pretty high pleomorphism, and there's a lot of karyomegalic and cytomegalic cells here. You can see that pleomorphism from outer space. Another really neat feature that I love about these, so see this nucleus here, for example, it kind of looks like it's got an inclusion, right? And especially if you are a path resident, you're probably training yourself to detect these inclusions and looking for stuff like this so it catches your eye. But this is actually an example of a pseudo-inclusion, and you can see a lot of these nuclei around here have this. What this is these cells are so big and floppy, and the nuclei are so big and floppy, that the cytoplasm invaginates into the nucleus, sort of pushes up into it. And then if you section that at a certain plane, it'll end up looking like there's an inclusion in the nucleus when it's just like a bump of cytoplasm invaginating in. So that looks pretty wild and has a neat sort of appearance. So, highly pleomorphic population. At first, maybe you're not sure exactly who these guys are, but if you look around, every so often there's a convincing kind of faint, dusty pigmentation in some of these cells. Or maybe you're convinced, I'm not sure. And then if you really look around, sort of adjacent to areas like this big bump, you'll maybe be convinced and start to see that some of these cells have more pigmentation to them. Oh, let's see. Here's another area where these sort of poorly pigmented cells are at. Trying to show off how some of these cells around here have some pigmentation to them. So here, for example, I would say this one is pretty convincingly neoplastic, and it pretty convincingly has melanin pigmentation. Long story short, this is feline diffuse iris melanoma. Likely all of it is feline diffuse iris melanoma, the same feline diffuse iris melanoma. It's just that there are some subpopulations of these neoplastic cells that have become quite poorly pigmented and have made these sort of mass effects that look tan clinically and that look pretty remarkable from low mag. A lot of feline diffuse iris melanomas will have this really high pleomorphism, just like this. And they look very scary, but actually the degree of pleomorphism, like the nuclear atypia, stuff like this, actually hasn't been linked to prognostic significance. So even though these guys look scary and highly pleomorphic, the degree of pleomorphism is not necessarily something that gives us more information about how this cat might do. The features that have been linked to prognostic significance include a mitotic count of 7 mitotic figures in 10 high magnification fields or more, presence of tumor necrosis, and extension extrascleral or into the choroid. And these features don't stack, essentially. So like if a case has all 3 of those in one case, it doesn't make it worse than a case that has 1, if that makes sense. So it's like 1 or more of those is associated with relatively worse prognosis. This case had 23 mitotic figures in 10 high magnification fields. So it does have a relatively worse prognosis, but not because of its wild pleomorphism. So there is this kitty for that kind of classic, just showing off classic feline diffuse iris melanoma. And then the other reason why this, well, classic with some interesting features. And the other reason why I thought this case was neat is this eyelid biopsy. It's so cute. So we have these random pieces of tissue. It's actually probably mostly subcutaneous in our sections here. We've got some muscle and collagen mainly. And then we've got these big bumps. So they called this dark material in the eyelid. These bumps probably looked kind of blue-gray clinically or grossly. And if we look at them, they're just cysts. They've got a pretty simple lining, usually just a single low cuboidal lining here. And the contents tend to be this sort of inspissated looking proteinaceous gel with maybe some cholesterol clefts and some like brown laden macrophages. Some of the secretion can be kind of iron rich. These are apocrine cysts, simple apocrine cysts. And this cat is a Persian, remember. So Persian cats are prone to multiple apocrine cysts and cyst adenomas, and sometimes even malignant tumors of apocrine origin developing in the eyelids. They can essentially develop multiple masses in their eyelids. And if you have multiple cysts, you could consider a cystomatosis diagnosis for these cases. The other classic in cats is Abyssinians are apparently prone to developing multiple apocrine cysts in their ears, for example. So just something to think about. And these cysts themselves are benign and totally excised. So these cysts at least are not going to recur, but this cat may develop additional apocrine masses in the eyelids. So a cute little twofer in this case. There aren't any questions about that. I will squeeze this one in 5 minutes. I think we can do it. Wait, what? Oh, I got 8.
Yeah.
Well, then we're definitely going to be able to do this. Whoops. Okay. So the next case is a 12-year-old spayed female peekapoo, Pekingese poodle mix. They describe mucopurulent discharge, periocular swelling and erythema, blepharospasm, episcleral injection, etc. Aqueous flare, a hyperpigmented iris. The pupil was stuck, smaller than mid-range, with 360-degree posterior synechia and fibrovascular membrane formation, and there was cataract in the lens. And they couldn't see past any of that in the front. This patient also, interestingly, they note, has a history of a dental performed with some teeth extracted. So keep that in mind. They do say that the dental was performed May 11th, and this eye wasn't removed until around late June. So it's a full month, maybe more, since the dental, which is worth keeping that in mind too. And they don't give us a duration of problem, I don't think, in this case. All right, so things to keep in mind. We didn't have a gross photo of this particular case, so this is a representative gross photo. The cornea is a little bit sectioned here, maybe a bit off center, but here's our cornea, and then this globe is just full of hemorrhage and pus, and we have a cataractus lens. And then one thing that you might see if you've got kind of a keen eye is right here, in this representative globe at least, we have this little tract of tan tissue that's running through maybe a little bit posterior to the equator, sclera of the globe, and we've got a little bit of sort of firmly adhered tan expanded tissue immediately adjacent to that spot as well in the orbital connective tissue. So that might have been something what this globe looks like. They describe in this particular case a ventromedial limbal firm tan scar, question mark, that extends slightly into the cornea. So there's a little bit of an indentation, there's a little bit of firm and tightly adhered tissue in the periocular connective tissue that won't easily remove. Usually if it's normal periocular orbital tissue, you can even peel it back from the globe with your thumbs. It's not very tightly adhered. Usually if it's stuck to the globe very firmly, it implies some degree of fibrosis, inflammation, something along those lines. All right. So, well, okay. Let's Here's our cute little peekaboo globe. We have our posterior synechia, the iris sort of stuck to the lens, and then tons of purple filling the globe, and pink, so high protein material and a ton of cells, and red, a little bit of hemorrhage. So we got that kind of exudate inside our globe. We zoom in closer, all that purplishness is neutrophils and fibrin. So many. So this is pus. Long story short, we've got a lot of exudate inside the eye. We've got a pretty severe endophthalmitis. As we look around within this pus, we have bacteria, little clusters of bacteria hither and thither. And a cute little feature is that some of these bacteria have this rim of basophilic material around them. It's not clear if there's bacteria in the middle of that one, admittedly. But trust me, here we go. Here's an example of where there's clear bacteria in the middle. So these are basophilic club-shaped projections deposited on the surface of these little dit dots that are most likely all bacteria. Some of them could be other types of foreign debris. And these basophilic club-shaped projections are Splendere Hopeley. An interesting phenomenon is that in pretty much any other location, Splendere Hopeley tends to look eosinophilic club-shaped projections. So keep that in mind if you're a pathology trainee. But in the eye, for whatever reason, it's basophilic, and we don't really know why. But this is most likely immune complex deposition, essentially on an antigenic stimulus, in this case, most likely bacteria. So we've got a septic endophthalmitis, long story short, and we want to know why. If we take a look at a ventromedial section of the globe where that tissue is tightly adhered over the globe itself, ta-da! We have purulent debris in the episcleral and periocular tissue, right where that stuff was tightly adhered. And we have this cute little linear tract that, at least at our examined plane, is extending through the uvea, if not the sclera. But most likely the reason why is that we have a bit of an oblique section of this site, where it probably would have extended all the way through the globe if we had caught it at a perfect plane. So here we have this stuff. The location of this is roughly at the ora ciliaris retinae. We have the retina right here, for example. So it's just a little bit anterior to like the equator of the globe or so in a ventromedial orientation. When we have a penetrating trauma, and this is most likely going to be a penetrating trauma that caused this, and likely it was contaminated and resulted in bacteria being carried into the globe, the location in the globe can matter. If it's more of a dorsal location of the penetration, it implies that the penetrating trauma likely came from outside the patient's face, and more anteriorly, it implies that it may have come from outside the patient. A more ventral location and kind of more caudal like this implies that it could have come from oral cavity. So going back to the history of a dental semi-recently, we would wonder in this case whether there was an accidental penetration of the globe associated with the dental. In a small kind of narrow penetration like this, we might wonder if it was like a needle, essentially one of the local anesthetic blocks that could have been involved. But it could potentially be dental tools as well. Briefly, don't have much time or any at all, really. 2 minutes. I have 2 minutes. Oh, that clock is slightly fast, eh? I keep being fooled by it. Just to show you, because it's kind of cool. Boing. So this is the posterior lens capsule, and it coils on itself nice and tight here, which implies that this lens capsule ruptured at pre-fixation, at least. So this penetrating trauma may have also got the lens a little bit. Long story short, dental accident is suspected in this case, but it could be some other trauma. We don't know. We can't rule out like a migrating foreign body or some other trauma that came up from the mouth, like a stick or something. Even though we didn't catch a foreign body in section, it doesn't necessarily rule it out. And we don't necessarily know the exact chronology since we don't have the duration in this case. I would wonder whether ocular signs started adjacent to the dental or not, for example. The dental was about a month ago or more than a month ago. But we would wonder about dental accidents. So in terms of dental accidents, patients that have smaller mouths seem to be overrepresented. So patients like cats or small dogs, probably because of decreased visibility or ability to maneuver. Procedures that require multiple extractions and are a little bit more complicated also seem to be overrepresented, which also kind of makes intuitive sense. And it is worth pointing out that we have a large number of eyes in the Coplow database, and there are a ton of dentals that go on all the time, all over, and we really don't have that many cases like this in the broad sense that present with dental accidents like this. From the Coplow perspective, nearly all dentals end in ocular penetration, but we have a bit of a sampling bias. So, you know, it's probably not all that common of a complication in a broader sense. Just pointing that out too.
Right, the submission contains the word dental,
We get
and
suspicious.
we receive it.
Yeah,
And it's
Thank
full of
goodness.
us.
that's full of us, exactly. So, and that one other thing is, we don't always find the site of penetration in these cases. A lot of them may be tiny needle pokes, so you may not necessarily catch them, and that is also something to keep in mind. There you go, dental accident, or at least suspected dental accident. That's it.
Thank you.
Hooray.
All right.
Want to meet for necropsy rounds at 10?
Stop the recording.
It's perfect. Everybody up there, but we probably just keep rounds pretty short and just head down. So the
The big balls are white. Well,
Right.
Yeah.
Good.
stop sharing.
Yeah, I can find some probably,
Just end the meeting and.
but not any I can recommend right off the top.
Okay.
because